All right, and it has the critical behaviors in the beginning, right, where you go and you check the doctor's orders and you wash your hands, you assemble the equipment. All right, but this is, what NAND are we actually referring to here? What nursing diagnosis when somebody is being fed artificially?
Self-care deficit and
feeding. You could go with that one. And to me, in some ways, that one almost means, though, that I'm hand feeding them. My favorite one for this is altered nutrition, less than body requirements, right? Deficient nutrition, really. Do you see what I mean? Okay, and because it's altered, they have to get fed with a tube down your nose. Am I right? Okay. And so, what are the confirming objective signs that a patient needed this tube again? What are the reasons for getting gastric intubation?
They couldn't swallow themselves.
Yeah, dysphagia is one of them, or the infection, or facial trauma, or something where they're not meeting their caloric requirements. Because some patients we let them eat all day and we feed them all night because they just don't hit the target. Do you see what I mean? We just have to buff up what they can do. Maybe they can eat maybe 400 calories or 600 calories. I worked in a burn unit. It takes thousands of calories to heal a burn, and we let them eat all day, and then we drip food into them all night because they just couldn't keep up to where we were headed with it because we needed them to have 4,000 or 5,000 calories, and it was really hard for them to hit that. All right, so that's one part of it. I have to formulate my diagnosis, and what's my goal in feeding someone?
So that they gain the caloric intake they need.
That's right. And how do I measure and know that they're doing
intake and out.
We're going to intake and output, but what I'm trying to do is maintain their body weight. Okay, I'm trying to maintain or improve their body weight. So when I'm looking at the chart, I'm looking how is their weight doing, and then I could actually look at lab tests that are indicators of nutrition. So what are the ones that we like to? We like to look at protein. We like to look at albumin. We actually look at something now that's a precursor of albumin called prealbumin. We look at their iron stores called transferrin levels to get a sense of what's going on. But a gross measurement is what is their weight doing and change from week to week. Because when you step on the scale today, it's really your report card of the salt you had yesterday. Do you see what I mean? I mean, I would love nothing more than to lose a lot of weight today. But it just doesn't work that way. You can lose a lot of water today. But people lose weight on that 500 calorie thing, from week to week, not from day to day. Okay. So I have determined, yes, my patient needs this. And then I actually have to have an order for the actual solution that I'm going to feed them, all right, because that's a dependent function. And now I'm up to the bedside and I'm talking to my patient. I've positioned them, which needs to be this head of bed up business, right? And I'm going to begin with my assessment of the tube, and I'm going to go to my assessment of the abdomen to see if it's appropriate to feed this patient. So how did we say we were going to verify that that is still in his stomach?
That you see the stomach contents?
Gastric residue.
Okay. Residual. So I could aspirate. Is one thing I could do is I could aspirate and I could look at it and see if it's stomach contents. We talked about that being a little less specific, but we're going to see people doing that. I could then take that, and if you work at a hospital where they do a litmus paper check, I could put the gastric contents on the litmus paper, and it would.
Oh, the pH.
The pH would be very low because stomach contents should be acidic, and so on. Do you do that up there? No, people don't. There's only Cedars and Children's who Good Sam are doing that. But anyway, there's a problem with that because we give people drugs to reduce their acidity because of the problem with gastric bleeding, ulcer, and so on. And then the other thing I could do is put my stethoscope on, right here, and I want my stethoscope. And I could do the insufflation where I put air in and I listen. Also not a very specific sign. But we'll see people doing that. But why don't I just start by looking at the patient. And if I came along and what I saw was this.
And you know
it moved.
Yeah, exactly. It moved. All right. So I could stop right there. I wouldn't be pulling things through it and pushing things through it or any of that kind of stuff because I already know I have a problem. All right. So I could reposition the tube. All right. And now, because I am repositioning, I do want to know that it is actually down far enough. All right. When a person has a tube placed, they should be able to breathe, talk. It shouldn't be that they're like, right, or turning blue or any of that kind of stuff. But people with very low levels of cognition or cranial nerve function, you can put a tube right in their lungs and they'll just look at you. And they may not particularly desaturate or cause a problem, and so on. I could look at the back of their mouth And the tube should be straight down?
Well, I mean, back there.
It should be back there, but straight down goes to your trachea. Esophagus is off to the side, so it should be off to the side a little bit, all right? It shouldn't be coiled up in their mouth, and I shouldn't see any signs of respiratory distress. It should be positioned like this. Now I move on to fussing with it. But if I saw that right off, I got a problem. All right. This isn't the right. May I have one of those catheter tip? This is a... Oh, yeah, thank you. That was a good idea. All right, so there are different kinds of syringes. These are very large syringes. These are 60 mil or 2-ounce syringes. And this one's called a Luer lock, L-U-E-R. A Luer lock is a threaded one. It's for needles, something like that. And this is called a catheter tip, meaning it's used with tubes. So you wouldn't do this.
Open the package.
Yeah, and they're labeled on the outside. See, the same thing, same size and the whole thing. But this is different. Yeah, this purpose is different. And if you tried to put this in there, this is all kinds of stuff. Well, for given different kinds of things. But this is a catheter tip. So I could do the, which is not my favorite, but I could do the insufflation. Takes a second for the air to get there. I could pull out gastric contents and look. I usually crimp the tube when it's open, all right, because if they cough, sneeze, whatever, they could blow stuff right up this tube straight on you. You'll only do that once. Anyway, and then you can put this on the litmus paper and check, all right. And now I want to actually do that residual check that Jason was talking about. I want to see what's residing or what's left in their stomach before I add food. So I'm going to pull out everything. And let's say they have a lot. May I actually have one of those containers there? Okay, and so there's a container like this at the bedside. There's 2 of them. So I would actually, oops, this one is the water one. So I could actually crimp the tubing and, put the gastric residual in here, and I would keep doing it until I got nothing. Until I got nothing, all right? I think ATI says 100, but the research stuff, the latest research says greater than 200 becomes an issue. Sometimes doctors will tell you, hold for a residual of 150. Sometimes they'll give you an actual number. The old rule of thumb was twice the hourly feeding, if they're getting a continuous feeding, and so on. But the new research is showing 800, or 200 rather. So if I put it aside and it's 150, what do I do with it?
You keep taking it out?
If I'm done, it was 150.
Oh, then you mark it.
Then I put it back, all right. I need to put it back because the current belief system is that you might be taking out their hydrochloric acid and fluid from their stomach and their nutrition. All right, so you actually could put it back in place, all right, and, just let it go down by gravity, all right, and put it all back in, and then I would rinse afterwards. I think this practice will go away if we could ever catch up to the research, because most countries like Japan and Europe, they're not putting residual back. They're replacing it with new tube feeding. It hasn't shown to affect pH, but that's our belief, and that's what the test will be in America and on NCLEX currently, because NCLEX reflects practice, not research. It's kind of interesting, and so on. But they don't want to put stuff. They think there's a risk of contamination. They don't want to clog the tube. All right, but let's say that wasn't the case. Let's say I got 400 cc's. 400 mils came out. That's almost a half a liter, huh? So what's up? The stomach's empty very fast. Your stomach is emptying, I think it's less than 30 minutes. Very, very fast after you eat a meal. Fat slows it down. A few things slow it down a little bit.